Good evening. I'm Jim Zirin. This is the digital age. Tonight's show is about Obamacare, health care reform. Republicans want to repeal it. Others seek to modify it. One way to modify it is to reduce the amount of fraud and abuse in the system. An effective management tool for doing this would appear to be analysis of the Medicare claims database. The Medicare claims database is a listing of all doctors receiving Medicare payments, the nature of the service they perform, and the amount that they get. The problem with the Medicare claims database is it eliminates the names of the doctors from public scrutiny. So the question is, how do we reform healthcare reform? Can we cause the government to disclose the names of the doctors on the database? What other reforms are indicated? Now, tonight's guest is an expert in healthcare policy. He is Joseph A. Califano, Jr. He was the Secretary of Health, Education, and Welfare in the Carter administration. He was the principal domestic advisor to President Lyndon Johnson when healthcare, Medicare was enacted in 1965. He is the chairman of the National Center on Addiction and Substance Abuse at Columbia University. And Joe, we're delighted to have you back with us.
Well, it's great to be here, Jim.
Now, we hear so much about Medicare fraud. What is the nature of the fraud? What kinds of fraud are there, and how can they be detected?
Well, some of it is raw fraud in the sense that it's claiming a service was performed that was never performed. But a lot of it, Jim, is because there are so many codes, and somebody will come in, particularly in the mental health area or with a drug abuse problem, and it doesn't quite cover what the doctor wants to do, so he'll put it in another category to provide the service. Those are the two basic large kinds of fraud. The database is an invaluable tool, there's no question about it. It should be more used than it is, and there are lots of ways to do that. I tried when I was secretary to release the names of doctors and services performed. I think it was at $100,000 or more. And ultimately, the American Medical Association beat me down and made it impossible for me to do it.
Well, they actually sued in court, didn't they?
They sued in court.
They claimed that doctors' names were private.
That's right. They sued in court and they won. I don't, I can understand the privacy related to patients. Did I provide you cancer surgery, or did I provide you psychiatric treatment, or did I provide you, some kind of heart treatment? And people, it's doctor-patient privacy. I can understand all of that. What I can't understand is if you don't name the patient, and you simply name the doctor. Let me take a simple example. Suppose we simply said, okay, for doctors that are billing Medicare $1 million or more a year, we want to take a look at what they're doing. Are they, I would think that just in terms of quality, you'd want to take a look at that.
Well, Newt Gingrich claims that fraud and abuse cost us as much as $120 billion a year. Do you think that's possible? Is that an exaggerated figure?
I think that's probably an exaggerated figure. I think there's the kind of fraud I mentioned, outright fraud. I didn't perform any service. There's the fraud of playing with the various billing codes. There's also, and in terms of fraud and abuse, there's also something called legislative abuse. I mean, it's the way they write some of these laws that create problems that otherwise wouldn't exist. When you look at all of it, I think a good start, personally, would be, let's take doctors that get $1 million or more per year. Let's make their names public, and let's look at the services they perform. We don't have to identify any patients.
The database discloses the names of hospitals rendering services, doesn't it? That's available
to the public. The database does that, and it's also, this is very useful not just for fraud. This is very useful in terms of the quality of care that's being provided. I mean, doctors may be providing a lot of unnecessary care. They may be providing not enough care. just in terms of professional review, internally, many hospital departments review what their doctors and attending doctors are doing in terms of the quality of care.
Now, the Wall Street Journal article in which you were quoted talks about a doctor who received more than $2 million in Medicare payments for recommending diagnostic tests outside her specialty. She was an osteopath. These were tests given to a geriatric group. The suggestion was they were needless tests. It's things of that kind that the database would disclose.
Absolutely, very important. And probably a lot of those tests were totally unnecessary. And I think it also reveals how much money there is in tests. You know, nobody has an interest. If I'm a doctor and I'm sending you to get tested here and radiation, x-rays here, and an MRI here and a CAT scan here, nobody has an interest in saying no. My interest may be simply to protect myself from lawsuits. I don't know what's wrong with you.
You mean if you're the doctor?
If I'm the doctor, my interest may be, all right, I need to do this. If I'm providing the MRI or the CAT scan, my interest is just doing it. I mean, there's so much profit in that world.
So there's a vested economic interest.
Every interest is to go ahead and provide the service.
And the patient really has no skin in the game, isn't that right?
Well, the patient is usually scared, dependent on their doctor. Doctor says, you know, I'm just not sure of that, you know, cough and everything you're complaining about. I think we better do a CAT scan.
There was this case that when he was budget director, Orzog told about at Mass General, where an elderly woman goes to see a neurologist and says she has a pain in her back. He said, oh, you need an MRI. So she said, fine, give me an MRI. He says, I have great news for you. You don't have a neurological problem. You need to see an orthopedist. So she goes to see the orthopedist. The orthopedist says, you need an MRI. She said, I just had an MRI. And he said, well, I've got to do my own independent clinical findings. So now the government is paying for 2 tests instead of 1. They put a stop to that. But this is the kind of problem that you're talking about, isn't it?
There's no question about it. And there's a lot of that. And a lot of that is, you know, one of the failures of the healthcare reform law. It really didn't come down very toughly on tort reform. I mean, a lot of these tests are driven by the doctor's fear that they'll be sued if they don't run the test, and somebody's found to have the disease or the problem.
As well as the economic motive.
As well as the economic motive.
Now, Joe, if certain tests are suspect, why not just simply remove them from coverage? Now, you don't want to remove MRIs, but I mean, the sleep disorder tests, they put someone in the hospital and they spend the night while they survey what's going on with their brain waves.
This is very tough, removing stuff from coverage. And it's actually going to be one of the major problems with having a highly centralized health financing system. In full bloom, Obamacare will be paying for, I don't know, maybe 60, 70% of all health care given in this country. At that point, what the federal bureaucrat decides will be covered or will not be covered will basically be effective throughout the entire medical system. Because if Medicare doesn't cover it, private insurers surely will not cover it, or they'll cover it for an enormous premium.
But certainly from the point of view of society, it's a much better route to minimizing fraud if doctors are deterred from fraudulent conduct rather than they're succeeding and then the government indicting them and trying to get the money back.
Well, there's no question about that, and that's why making things public. And you know,
sunlight is the greatest disinfectant.
It is. You know, years ago, I was on the Chrysler board and I looked at their healthcare system, and we found incredible things. I mean, we found 2 appendectomies on the same patient. We found people with foot problems being dealt with 1 toe at a time. And we found, you know, and remember, health care treatment follows money the way a cat follows a dead fish in the garbage. And in those days, the greatest...
Oh, that's a great Brooklyn analogy.
But the greatest number of psychiatrists per capita were in the nation's capital in Washington, D.C., and in Detroit, Michigan. And you know why? Because the federal plan covered all psychiatric care, and because the UAW plan covered all psychiatric care.
Well, that's an interesting fact. Now, the AMA says that if you publish the names of the doctors, first you'll interfere with the doctor's privacy, but also it will deter doctors from treating Medicare patients because they've got to do it in a fishbowl.
I think that's nonsense. I think what will deter doctors from Medicare is what's happening here in New York and some other large cities, which is the Medicare reimbursement is so low that the doctors say, I'm not going to take Medicare patients. And we're seeing that at every hospital, every major hospital in this city, and we're seeing it in every major city in the country.
Now, I think it's fair to say, every other government contractor, aside from doctors, has to live with public disclosure of how much he's receiving for that contract. And that is certainly a very prophylactic kind of disclosure, because then the public through the press can see who's getting what.
Well, and it's also prophylactic. If Dr. A is treating back patients and he's ordering 10 times the number of MRIs than any other doctor that's treating back patients, you know, it's time to look at Dr. A. It may not be fraud, may not be abuse in an abuse sense, it may just be lousy medicine. And we have to face the reality. One of the complaints of doctors and hospitals in the whole Obamacare situation is, oh, we're going to have people looking at what we're doing. Sure, we should have people looking at what they're doing.
Yeah.
Most corporations do that now.
Well, and a major badge of fraud is doctors treating people outside their specialty. So if you saw an obstetrician treating someone for back pain or for a knee problem, then you would suspect that they really don't know what they're doing in prescribing tests.
Absolutely. And also, I mean, you mentioned prescribing tests, also prescribing drugs. I mean, we have an explosion in this country in doctors prescribing OxyContin. A fantastically effective painkiller, unbelievably addictive, supposed to be used only in the worst cases when other pills fail, other painkillers fail, yet it's being used, just pumped out there because doctors, you know, family doctor, 40 people in the office every time he walks in, has this pill, gives it to the old ladies with arthritis, and they say, he never hears from them again. It's wonderful. They're happy.
Well, it's interesting that most of the Medicare fraud which resulted in convictions last year involved fraud on the part or related to the use of drugs or the prescription of drugs or involving drug companies. And so you've really put your finger on something. But the other issue that's so interesting nowadays is that you hear all the time doctors don't want to treat Medicare patients anymore.
That's right.
And why is that?
Well, the reimbursement rate is too low, and they feel they don't get enough money. This is particularly true in large cities, where it's very expensive to practice medicine and very expensive to live. This is going to be a major issue. I mean, I think at most major hospitals here in this city, lots of doctors have opted out of Medicare. They won't take Medicare patients. They don't want to be restricted to that level. And what we'll have is, it won't be dissimilar from what's happening and what has happened over the years in Britain. You know, a certain percentage, it's somewhere between 5 and 15% of the British people buy out of health care. They get private insurance. They go to doctors who don't work in the National Health Plan, who are excellent doctors, and they've got enough money to pay them. That's happening here. No question about it.
Well, Medicare is supposed to reimburse the doctor for the customary fee charged by doctors in the community for the service involved. I mean, isn't that enough for them?
Well, it's usual, reasonable, and customary.
Yeah,
and
put that in to avoid a charge of socialized medicine. But
yeah, but you know, well, this is, you know, what's reasonable here is this, and if you look at all we've got to cut health care costs, and you look at what all the politicians say. Pay doctors less, pay hospitals less. Theoretically, it's easier to do that than it is to say, well, we won't cover this procedure. or we'll charge the patients more in order to cover the cost of Medicare. You know, that's politically difficult to do. But they're going to have to come. They're going to have to make some accommodations here.
Well,
The
that's
best doctors, you know, just Jim, think of it. You're the most terrific neurologist in New York City or Boston or Baltimore, and you can be paid twice as much by patients all day long if you're not taking Medicare. If you're taking Medicare, you're paid about half of what you get from private patients, and you got 4 kids. And they're going to, what are you going to do? You're going to go and take care.
Follow the money.
Follow the money. And you know, and what do you do? Are you socially inept or socially, you know, don't give a damn? No. What you'll do, you'll have a half a day a week you'll work in a clinic or do something like that.
So what's the answer? I mean, should there be Medicare vouchers or with private insurance? Should we privatize Medicare, as many Republicans want to do?
The answer is that the only way to reduce health care costs in this country is to keep people out of the sick care system. I mean, the answer is you deal with obesity, you deal with smoking, you deal with excessive drinking, you deal with substance abuse, you deal with unhealthy failure to exercise. You've got to change the culture of people.
And how much is there in Obamacare? How much money for what, as a percentage or otherwise, for preventive medicine?
Very little. Very little. And you know, it's not only it's not simply encouraging people to do it. You know, we need the public health care plans. We need to provide coverage, so to speak, of preventive services. There is coverage in Obamacare for annual physicals, but we need to make it costly to the patient. We need to say, we're providing free flu shots and we're providing free pneumonia shots. Now, if you don't get the flu shot or the pneumonia shot, and you get the flu and pneumonia, you pay the doctor. We're not going to pay. Now, you know, I tried a little of that when I was secretary, and you probably don't remember Claude Pepper.
Oh, sure.
Claude Pepper, the great protector of the elderly and a good friend when he was on, just excoriated me. I mean, he so attacked me for not protecting the elderly. My mother was a retired school teacher. On the front page was this attack. She called me about it. What are you doing? I mean, that's the problem. But we've got to start doing some things like that. It gets tough in some areas. I mean, if you say, okay, if you're more than 20 pounds overweight or some percentage overweight, then unless you take care of that, we're not going to pay for diabetes or other high blood pressure, perhaps, or other diseases like that. That gets tougher because, you know, there are people that can't, whatever they do, control their weight. But we're going to have to look at things like that. There's no question about it.
Well, the House of Representatives has repealed Obamacare, Republican majority, and now it is going to go to the Senate. Minority Leader Mitch McConnell has said, quote, "We intend to go after this health care bill in any way we can. It's the single worst piece of legislation that has ever been passed in my time in the Senate." Now, are you critical of Obama for not marshaling more bipartisan support for his program?
I think he should have. I don't know what, and I'm not intimately familiar with the climate down there, but let me go back. When we passed Medicare and Medicaid,
this is 1965.
This is 1965. This was very difficult. We attached Medicare to the Social Security increase that the Senate was passing in 1964. In those days, Congress, every 2 years before the election, voted an increase in Social Security. We figured that we'd get that. In the conference with the House committee and Wilbur Mills would not take Medicare. Lyndon Johnson killed the Social Security increase, which everyone thought was crazy. The next year we came in, and Johnson kept saying, we've got to have at least half the Republicans in the House and the Senate. This is complicated legislation. Complicated legislation is not self-enforcing. You need a lot of people to do it. You need doctors, you need hospitals, you need nurses, you need states on the Medicaid to get it done. And so in the House and the Senate, we got about half the Republicans. Then we passed it. Otherwise, he said, they'll go after you hammer and tong. They'll block your appropriations. What are the Republicans saying now? We're going to block appropriations for Obamacare. Yeah, he should have been willing to give a little more and get some Republican support. Now, you know, if you talk to people down there, they say, you know, you don't know what the world is like today. It's impossible to get Republican support. There are a lot of things you could have got Republican support for. No prior existing conditions, you know, regular examinations.
I mean, they represent people too.
So. Yeah, and we're going to see a problem. I mean, there will be a vote in the Senate. I don't think it'll pass the House bill, but McConnell has the power to get a vote there. And then there'll be these battles over appropriations, and it's in that area, and as a result of the ability of the Republicans to hold back appropriations, that I think we will see amendments to the Obamacare bill.
So do you think there's room for compromise between the two parties to achieve some kind of reform of the bill?
I think there is. The more people begin to understand this bill, the more people say, whoa.
Understand, it's 1,500 pages.
But understand some things.
You did it in less than 50.
That's correct. We did. Times have changed.
I mean, Lincoln's Gettysburg Address was written on the back of an envelope. It doesn't have to be long.
Sure. But the regulations for Medicare and Medicaid are volumes.
Yeah.
So I think the thing is to start identifying the provisions that they absolutely can't go after. And there'll be some compromise along the way over the next couple of years. This is a very complicated bill. I would expect, and you know, it phases in over the next almost decade. And there are other pieces coming. You know, the bill
what's coming is $1 trillion over the next decade.
But yeah, the bill is you know, a health reform bill that saves money. But let's be realistic. It saves money by not giving doctors their annual increase in fees. Every year they've blocked that. It saves money by cutting $500 billion out of Medicare. Not going to happen. It's in the real world. It's not going to happen. So it doesn't save money in that way, and there have to be some compromises made on that part of it.
But you were in the thick of things in 1965 with Congress and the White House and at LBJ's side the whole time and getting the bill passed. Were our politics as polarized then as they seem to be now?
No, but we had some difficult problems. They weren't as polarized because, you know, there were liberals in the Republican Party and conservatives in the Democratic Party. People stayed in Washington, they talked to each other. But we had a couple of really tough problems. Medicare, the major issue in getting Medicare adopted around the country was the fact that we had passed the Civil Rights Act in '64, and thus Medicare became a vehicle for desegregating every hospital in the country. Any hospital that got federal funds had to be desegregated. That was a major problem. The doctors didn't want to join Medicare. The AMA came to see Lyndon Johnson to talk about that. Before the head of the AMA could say anything, Johnson said, I have a war in Vietnam. I need doctors to help the civilians in Vietnam. Will you start a program to send doctors over for 6 months? He said, yes, we will. Johnson said, bring in the press. The press came in. Johnson announces this program. The first question from the reporters were to the doctor, head of the AMA, is the AMA going to support Medicare? Are doctors going to join Medicare? Lyndon Johnson says, puts his arm around him, he says, these men are willing to risk their lives for this country. Of course they're going to obey the law of this country. They'll be in Medicare. That's the law of the country. And the AMA president said, yes, we will, Mr. President. That was the end of it. But the race thing was as tough as any issue Obama faced in passing this bill.
You look at Obama's accomplishments in the 2 years that he's been in office, and there have been quite a number of them, the START Treaty and resolving the financial crisis, and then, of course, universal health care, which is perhaps the greatest accomplishment of his administration. Do you think it really provides benefits to the American people and will be regarded as such by history, or do you think it's flawed?
No. I think the bill will be amended in several ways, some of them, many of them proposed by the administration. Looking out this is certainly the signature achievement of his first term, and could easily be the signature achievement of all of his terms. You think about the sweep of history. I mean, Roosevelt didn't attach health care to Social Security because he was afraid he couldn't get it passed. Truman tried to pass health care, couldn't get it done. Johnson came up and passed Medicare, covered everybody over 65 and the disabled, and Medicaid to cover the poor people.
Well, so I have a question for you. Should we reform healthcare reform?
We need some reforms in healthcare reform. We need more energy, both carrots and sticks, on the issue of health promotion and disease prevention.
Well, we have to wrap up. Joe Califano, this has been absolutely marvelous. Thank you so much for coming by. And thank you for coming by. Tune in next week for more on the digital age. For the digital age, I'm Jim Zirin. Good night, all the best, and visit our website, www.digitalage.org.